الأستاذة الدكتورة نوها عرفة والدكتورة إنجي نصر هيكلمونا عن الجونادوتروبين ستيميوليشن تيست.
مساء الخير، ألف مبروك يا أستاذتنا غالية وشكرا جزيلا على الدعوة الكريمة. هنبدأ مع إنجي إن شاء الله.
حاجة النهارده هنتكلم عن واحد من الموست وايدلي تست في الاندوكراينولوجي كلينيك هو الكريونيك جونادوتروبين ستيميوليشن تيست او ال HCG ستيميوليشن تيست. بس خلينا الأول نبدأ بال our cases. Our first case is a 2.5 years old child reared as a female presented to the endocrinology clinic for assessment of accidentally discovered palpable swellings in the inguinal region. By examination, our patient has a complete female external genitalia with a clitoris of 0.6 cm, 2 genital openings, 2 separated labial folds, and bilateral palpable inguinal swelling with a Quigley score of 6/7 and external muscularization score 2. Our second patient is a 40-day-old infant who was also assigned as a female, presented for assessment of atypical genitalia. By examination, our patient is a clitoris like phallus, 2 genital openings, 2 labial folds with posterior labial fusion, bilateral palpable inguinal swellings with a Quigley score of 5 and EMS score 2. We started investigating our patient with karyotyping that revealed 46XY for both patients. The next step was hormonal assessment for our patient with the HCG stimulation test, and these are the results of our patient. But first, Dr. Noha Arafa will talk to us about the value and how to do and the interpretation of the HCG stimulation test, and then we get back to our patient.
زي ما حضراتكم كلكم سمعتوا في كل البرزنتيشنز اللي فاتت regarding the dynamic test. What we need in any dynamic test to know why we do the dynamic test and how to do and the different protocols and what are the expected adverse events during that test and the interpretation. For the HCG stimulation test especially, we ask ourselves 2 questions. Why we do stimulation test and why we need HCG especially for the stimulation. So to answer this question, we have to go back in the physiology of the functional and gonadal differentiation in the normal 46XY male. As you all know that the normal testes had 3 types of cells, the Sertoli cells and the interstitial Leydig cells and the germ cells, spermatogonia. During the intrauterine life, under the effect of very complicated genetic interaction, the FSH stimulates the Sertoli cells to produce the anti-Mullerian hormone, which causing regression of the Mullerian duct, which leading to allow the Wolffian duct differentiation. And under the control of the LH, the Leydig cells started to produce the intratesticular testosterone, which stimulate and complete the proliferation and the differentiation of the normal external male genitalia. And this, in this part, we have to discuss a very important point that is the pattern of the normal LH and the FSH production. In the normal neonatal life and after birth, we have 3 stages of the secretion of FSH and LH. We have what is defined as 3 surges for the FSH and the LH secretions. During the embryonic mid-gestational age, we have a surge of LH and FSH, then decline to the very low levels at birth, then starting to increase again after 1 week of birth and peaking at the age of 2 weeks. Within 2 weeks to 10 weeks, then decline again towards the 4th to 6th month. And this golden period is called mini-puberty, which does not need any stimulation to detect the basal androgens during that important period. Then the FSH and the LH started to surge again with the start of the puberty. And that is the answer of the first part of the question, why we need to do stimulation tests. as the axis is quiescent during the prepubertal period after passing the mini-puberty. Then the second part, why using HCG? It's a glycopeptide. It has a biological action like the LH, so we need to do the stimulation with that molecule, which acts like the normal LH. This HCG, it's normally produced by the syncytial trophoblast of the embryo, and it could be extracted from the urine of the pregnant woman, or it's modified. It's made with the modified technology like the recombinant DNA technology. What are the indications of HCG? We do the HCG for detection of the functioning testicular tissue in patients with cryptorchidism, or to evaluate the Leydig cell function in prepubertal boys, and also to evaluate the testicular biosynthetic defects. We have many different protocols for the HCG stimulation test. We have the short stimulation test and the prolonged stimulation test. The short one is the one which is widely used. For the short stimulation also we have different protocols, the single dose and the 3-dose stimulation test. Different preparations are present in the injection market with different brand names and different concentration. And for the 3-day stimulation test, I will start with it as it's the most common protocol used in many centers. For the 3 days, we have different calculation methods for the doses. We have the age-based calculation and the fixed dose calculation. As you see here, the age-based, according to the age, is less than 1 year. We use the 500 unit. For 1 to 10 years, we use the 1,000 unit intramuscular. And for more than 10 years, we use 1,500. For the fixed dose calculation, we use from 1,000 to 1,500 for 3 consecutive days. And this method, that is the method that we use at our center, and it is the method provided in the DSD consensus guideline revised at 2022. The timing of the sample, the sample is done baseline before the injection and 24 hours after the last injection. And the sampling includes testosterone and DHT and androstenedione. For the 1-dose stimulation test, it's based on the weight. It's 100 per kilogram or 5,000 per 1.7 millimeter square. The timing of the sample is the same like the 3-day sample on the day 4 from the first injection and including the same profile. For the prolonged 3-week stimulation test, it's starting like the 3-day method. Then we continue for 2 weeks, twice weekly. Then we do the sample on day 22. And it's needed for patients with cryptorchidism, but with patients اللي بيبقوا الابdominal gonads ممكن ما تبقاش visualized, or in the patients we suspect to have hypogonadotrophic hypogonadism, which need a more prolonged stimulation for the Leydig cell function. For the interpretation of the test, do tell that the test is labeled as normal if the levels of the stimulated testosterone elevated to double the fold, the basal fold, or reach the upper limit of the prepubertal values. And there is important ratios that could guide us for different causes of the male with undervalorization, like the ratio between the testosterone and DHT if elevated more than 20, or the testosterone and androstenedione if less than 0.8. We have this nice algorithm which guide us according to the values of the androgen levels for different parts for 46XY DSD differential diagnosis. What are the expected adverse effects for that test? It's a theoretical adverse event, and it's not reported for the short stimulation test. It's just for prolonged duration of use of HCG. It's like the behavioral changes, the virilization, the bone age advancement, and the germ cell apoptosis. And back again with Engy to our patients to try to analyze after this summary for the interpretation.
بعد ما عرفنا how to interpret the HCG stimulation test with Dr. Noha, let's get back to our patient. Our first patient has a total testosterone level after HCG stimulation of 0.04, which is less than the pre-pubertal upper limit, and it's definitely less than double the pre-HCG level. So our patient is labeled as having insufficient testosterone response to HCG, in spite of having a normal or even high anti-Mullerian hormone levels. So according to the algorithm Dr. Noha showed us, our first patient is diagnosed as having Leydig cell hypoplasia. What about our second patient? Our second patient has a total testosterone level of the HCG stimulation of 2.8, which is more than double the pre-stimulation level and definitely more than the pre-pubertal level, with a testosterone over DHT level ratio 43, with normal anti-Mullerian hormone level. So our patient, and also according to the algorithm, our second patient is diagnosed to having 5-alpha reductase deficiency. So from our patients and from Dr. Noha presentation, we have other tools for assessment of the testicular function in addition to the HCG stimulation test, which is including the anti-Mullerian hormone, the NBP, and insulin-like peptide 3. Here are our references, and thank you.
طبعا انتوا انكفرت يعني منطقه اوبسكيور ومعقده، وعملت لها كلاريفيكيشن لدرجه ان هي بقت واضحه. فانا بشكركم على ده. انت عملتي ستريس على فتره الميني بيوبرتي، ودي برضه فرصه ننتهزها ان احنا نفسرايز الامبورتنس بتاعت الايرلي سكس دايجنوزس للبيبيز، للحالات الدي اس دي لما بتتشخص بدري. عندك كانوا قبل كده انت عملت لها شرينكج ب 2 months or 3 months of sureness، لكن هي كانت بتبقى 6 months overall. على الاقل عندك 4-5 شهور تعرفي تعملي فيهم البيزل تيست وتوفري على الفاميلي والبيشنت عناء بقى فيوتشر كوست وتحاليل فيها ستيميوليشن بكل بقى الفرايتيز بتاعتها وكل الاريا اللي هي بتاعت الجونادال ديسجنسز. لا يسعنا الى ان احنا نتوجه بالشكر للمجموعه اللي اشتركت النهارده في تقديم السيشن دي. بروفيسور شيرين عبد الغفار دايما بتشجعنا ان احنا نتواصل ونتراكت ونتعلم اكتر واكتر ونشارك الاكسبيرينسز بتاعتنا، ودي حاجه مهمه قوي في الفيلد بتاعنا. ميرسي حضرتك.
انا اللي بشكركم جدا جدا جدا، احلى سيشن واحلى ناس واحلى تيم يعني من كل جمهوريه مصر العربيه الحقيقه، وسيشن رائعه وبرزنتيشن سكيلز هايله وفيري براكتيكال. I'm so proud of you all، وكمان proud بكل